Thank you,
Neeta.
sir. Thank you very much. Good afternoon, one and all. It's my pleasure and privilege to be a speaker of this magic of CICS Session 2. Thanks to AIOS, APAO and ISM CICS for this wonderful opportunity. Today I'll be talking on a very innovative technique, that is Dr. Boramani's Customized Incision Cataract Surgery. In recent years, the advancement in cataract surgery has really raised the patient expectation of a visual acuity and the surgical result as well. And the astigmatism has definitely a very important impact on the final visual acuity. The prevalence of astigmatism is definitely significant among the cataract patients. So there are different options which are available for the astigmatic management. Here I will be talking about the scleral wound modulation and its impact on the astigmatism. So here I will take you through examples. We see in first photograph the corneal topography pre-operatively of a cataract patient, 0.13 diopter. Patient underwent the scleral modulation surgery, and post-surgery 3 weeks the corneal topography shows 0.17 diopter. So there is no surgically induced astigmatism. Second interesting example of a higher astigmatism, here we see 2.04. Here patient opted for the autofocus lens, that is a multifocal lens, and patient underwent the scleral wound modulation surgery. Here we see the post-operative corneal topography value of 0.43. Attoref shows 0.25. Patient is enjoying 6/9 and N6 vision. So these two examples shows us when the patient did not have any pre-existing astigmatism, patient underwent a customized incision cataract surgery and there was no induced SIA. Second patient we saw higher astigmatism, patient underwent customized incision cataract surgery and that was treated with the scleral wound modulation. So definitely scleral wound modulation has an important role to play to manage the astigmatism. Now the present literature tells us what is the advantage of phaco over CICS is that it induces less astigmatism, but there is no available data how the scleral wound modulation has a good impact on the astigmatic management. So the principle is very simple. If your incision is straight, large, that induces the astigmatism of 1.25, and as you go away from the limbus, that your incision becomes more and more curved, the induced magnitude of your astigmatism is less, as only the central part of the astigmatism takes place. So I'll take you through the algorithm which is derived from Dr. Boramani's study, and this will help us for the scleral wound modulation. If we have a incision of a 7 mm, superiorly it induces the astigmatism of 1.7 diopter. Further reduction in the size of incision reduces the magnitude of astigmatism. Superior curved incision further reduces the magnitude of astigmatism, as we see in the center. Perfect U-shaped incision literally does not induce any astigmatism. As we are aware, the temporal incision are weak in neutralizing or inducing astigmatism. Temporal straight incision of 7 mm induces or neutralizes only 1 diopter of incision. As the further reduction in the size of incision reduces again the magnitude of astigmatism, and temporal curved incision, they do not induce any surgically induced astigmatism. So this slide is very important. So here we say the principle of customized incision cataract surgery is that you will have to place your incision, center your incision on the steep meridian. So whatever may be the size and the shape of the incision, so the vector forces acts on both the sides and helps in neutralizing the astigmatism. So this is the slide showing the surgically accessible area for the customized incision cataract surgery. So to get a perfect desired scleral wound modulation, find out your own SIA. There are different calculators available on internet. Find out your own SIA for that particular type of incision. Insert your K1, K2 preoperatively and postoperatively. That will help for the perfect scleral wound modulation. Again, I'll take you through few more examples of different magnitude of axis, different magnitude and axis of astigmatism, and how this scleral wound modulation helps in neutralizing. Here we see a preoperatively 0.28. Patient underwent a perfect U-shaped superior incision and there is hardly any induction of SIA. Here is a little higher astigmatism of 1.12. The axis is 97. Superior straight little large incision has neutralized the astigmatism to 0.15. So here again a slightly higher astigmatism, 1.24. Look at the axis. The temporal straight incision has reduced the further astigmatism. Again a higher astigmatism. Here the patient opted for a multifocal without toric. So we see a magnitude 1.97. A straight superior nasal incision with the multifocal lens. The post-operative corneal topography shows 0.15 diopter and patient is enjoying 6.6 N6 without toric. So the axis reference marking is done when the patient is sitting position, and the axis marking is done when the patient is a lying down position. Here is important to mark that once you mark your steep meridian, center your incision on the steep meridian. So the other video also shows the 39-degree axis marking, and the straight incision is centered on the steep meridian. So this customized incision cataract surgery and its impact on astigmatism was published in the prestigious Journal of Indian Journal of Ophthalmology. So here the surgically induced astigmatism is innovatively used to treat the pre-existing astigmatism. So it is a surgically corrected astigmatism. Here the incision is no more small, but it is customized as per the pre-existing astigmatism. So the proper terminology would be here, the customized incision cataract surgery. So few important take-home points. The top priority always is the patient safety. So once you are fine with any grade of a nucleus management through relatively small incision, then you start planning this. First, find out your own SIA. Second is preoperatively know the astigmatic magnitude. Magnitude will help to decide the size and the shape of the incision, and the axis will decide the site of incision. Mark the steep meridian and center your incision. So to start with, you start with the accessible area, maybe superior or superior temporal or temporal, that will give the good results. So customized tunnel engineering will definitely help out, or at least minimize the stigma of astigmatism. Thank you for attending and patient hearing.
Thank you, Neeta, for a wonderful presentation.